This is our first. It's our inaugural showcase of our first Global Health Legacy Fellows and their projects and their work. And we're really delighted to have everybody here today. Dr. Rousseau, I'm going to turn it over to you.
Great, thank you. Dr. Douglas and I are the co-founders of the GW Global Clinical Care Alliance, and we are delighted to be those who are responsible for administering a wonderful gift from the Davis family, GW alumni, who have funded for 5 years this fellowship. So this is, as Dr. Douglas said, the end of the first year. The three awardees are going to present their work today, and stay tuned. New applications are being accepted now for the second cohort. So with that, I'll turn it over first to Dr. Jerry Oommen, who is going to present his work, followed by Dr. Singer, and then Dr. Naithani. Jerry, please proceed.
Good afternoon. Thank you for this opportunity. So let me share my screen. Having trouble opening up in presenter mode, so we're just gonna do it like this. So let's get started. So my project's titled Scaling Up Emergency Resuscitation in Uganda, using simulation, point of care ultrasound, and team-based training for REACT teams, which are resuscitation action teams. So as far as some background, some rationale, emerging conditions, medical conditions, I have a significant global impact, even more so in LMICs, making this topic of emergency resuscitative care very important. The Uganda Ministry of Health accordingly has recognized this and prompted prioritization of these acute emergency care needs from a national perspective. Additionally, emergency medicine is relatively new, so it serves as a little bit of a limitation. There's only two residency programs in Kampala and Mbarara, and these emergency trained providers are primarily located in these more populated areas. So there's a need for a variety of healthcare providers from in all skill levels to be trained in like the most basic emergency care skills to be able to respond more promptly to seriously injured or critically ill patients to improve health outcomes. So the ministry, in conjunction with various nonprofit organizations, had implemented these resuscitation action teams or REACT teams, which were multidisciplinary teams composed of various specialties, various skill levels, from paramedics to nurses to doctors, to respond and identify and initiate management of these patients. But amongst these REACT teams at various institutions, they still identified various needs, things like medications, equipment, as well as continued education beyond just the initial implementation of these teams. So our project aimed to develop a rapid response and ultrasound-based curriculum to fill some of those gaps, provide a point-of-care ultrasound device to help facilitate the ultrasound knowledge goal, and then deliver education virtually to the three sites that we determined, being Mbarara, Katakwi, and Yumbe in Uganda. So three diverse areas in Uganda in terms of both location as well as resources. And then ultimately to assess the feasibility and accessibility of our proposed pilot project. So we were able to, this is just an example of the butterfly ultrasound that we were able to give to each site. And then again, as in the map, the locations. The ultrasound, like the point of care ultrasound, is particularly important because Mbarara is a more larger health hospital center versus Katakwi and Yumbe are very small hospitals. They don't have access to X-rays or CTs, They do have like a larger ultrasound machine, which is only operated by the radiology department, which is not always there. So makes the accessibility to a device like this, a handheld device that's easily usable for emergency situations, very important. So in terms of the project timeline and the progress that's been made, so the initial phase, August to December, was bunch of meetings with various stakeholders, leadership from each of these sites, as well as the Ministry of Health, to determine which sites we would be meeting with, kind of how we should outline this project and the education delivery. So it took some time to get things up and running. Additionally, with holidays, it was difficult to kind of initiate things sooner. Also, meetings with the ultrasound, the Butterfly company, to try to facilitate purchasing of these devices. So there's some initial upfront time. Then in January, I was able to go and physically visit these three sites, deliver some teaching, deliver the ultrasounds. So it was my first in-person opportunity to interact with the participants and leadership in this project. Then from February through July, it's been delivery of virtual education of the curriculum that we had done. And then looking forward into July and beyond, it's going to be assessing what we've done so far, and then ideally sharing the results to hopefully in a conference setting, and then kind of figuring out what the next steps will be from there. So some of the photos from the initial visit. So um, here in the first picture is at Yumbe. Dr. Owarinawe is one of the emergency physicians that trained in some of the bigger sites and then came to this very rural site of Yumbe. So presenting them with the ultrasound, a couple pictures in different settings of us immediately using the ultrasound that we were able to share, some in teaching, some in a clinical setting. Um, Another picture of me discussing the proposed project with potential participants. And then in the bottom right, we have a visit to the Ministry of Health to meet with some of the leadership in emergency medical services that were part of helping guide us in terms of making sure what we were doing was in alignment with their vision as well. So as far as the virtual teaching since then, they've been conducted via Zoom, so including members from each of these sites. These is an example of the outline. It's just a monthly session, trying to make it as little burdensome as possible for the participants who have their normal clinical duties and are doing this, taking extra time to participate. So various just high yield topics, high yield things that ultrasound could be easily and productively applied to at the bedside. Um, and then this is just a picture of one of our colleagues, Dr. Emran, and his participants in Katakwi. And then in the bottom left is just an example of one of my colleagues, Dr. Malika, and mentors who's leading a simulation session. So attempts to run a simulation as best you can virtually, and try to get as much of the applying of the knowledge and ultrasound skills as you can. And this is just a shot of me just demonstrating the basic components of the butterfly ultrasound, which was just a technical aspect of it was also a learning curve in addition to the clinical aspects. As far as ultrasound scans, not only do they have access to the ultrasound, they're able to upload and save the scans to the cloud. So we're able to take a look at the ones that they have saved, and discuss them during sessions. Let me see if this will play, but this is just an example of, I don't know if it will. This is an example of someone doing a fast ultrasound of the right upper quadrant and showing that there's evidence of likely internal bleeding present. So it's a great example of an ultrasound scan that we're able to talk through and discuss, and learn from collectively, for even though it's just done at one of the sites. So throughout the project, there's been some challenges. The site leaders, again, two of the sites just have one emergency physician that's present, so they have numerous obligations. So they're not always able to rally the troops and have full participation. They're really critical to their sites, and they're really also critical to encouraging and increasing engagement in this project. So that sometimes has been a limitation, and it's not always easy to kind of work around those things. Internet connectivity at these sites, especially the more remote sites, not always reliable. So that's something we've learned kind of along the way. Additionally, quantitative measures, not always able to the participants not always wanting to self-attribute the scans due to self-consciousness, not always saving the scans that they do. So in terms of like project goals, as far as wanting to know how many scans are they doing, how much are they from a measurable standpoint getting from this, it's some of those things become difficult to measure. But and then buy-in, 15 participants were included in the project. It's been variable. We're up closer to like 50% of participants generally participating in a given Zoom session. But without, like, there's no certification or compensation. It's entirely voluntary. So I guess not surprising that that's hasn't been entirely where we wanted to, but it's just challenges we've learned along the way and things we have to think about in terms of how we plan these for the future. But despite challenges, it's always trying to keep the big picture in mind. So this is an anecdote from one of our colleagues in Yumbe. So describing, reported yesterday evening that we used the POCUS butterfly to diagnose a patient with an ectopic pregnancy. She and her husband were unsure because she wasn't having her periods. Ultimately, they were able to identify that there was bleeding in the abdomen. They were able to take her to the OR, and they identified blood and a ruptured ectopic, and were able to ultimately save a life. So, in a remote setting like Yumbe, um, they otherwise might not have gone to the OR to do this procedure if there wasn't that high concern. Additionally, they had presented to other healthcare centers, smaller ones, and been diagnosed with various things before coming to this ultimate diagnosis. So, an example of how that ultrasound was helpful in guiding more emergent management. This is just a video. To ignore the picture, it's more so for the audio, but another story of Dr. Emran talking about.
A 70-year-old female, and she had been hypertensive for quite some time. And she came with features kind of suggestive of malaria. But when we assessed her, her pressures were high, and when we did abdominal exam, she had a pulsatile mass. So we just got curious and put the ultrasound scan in the abdomen. And we saw something like a flap. What you're talking about, that tissue in the middle, in between. And so we decided to actually refer that patient to, we call it a Heart Institute. So it's from there they did CT angiography, and they found that she had a very big, like a massive, big aneurysm.
So just two examples of kind of the big picture is ultimately um, that this device and this education is able to help identify things that then lead to the patients being more urgently transferred to higher centers of care, and ultimately lives saved. So it's just it's exciting to hear these stories from them, um, and take and then takes a moment to step away from just the minutia of like the project details itself. But ultimately, next steps, the final session's in July. The initial plan was to make one more visit to Uganda, but with the Ebola situation, from a purely safety standpoint, I'm not gonna be able to go. So we'll be doing a virtual session in July. Subsequently, we'll do a survey of the participants to kind of assess the acceptability and feasibility of this pilot educational program, and then hopefully share findings at a national conference in November. And then subsequently we'll meet with leadership and evaluate survey results and kind of figure out what the next direction will be from here. But that's all I have. Thank you.
Well, Jerry, thank you very much. Dr. Oommen, this is a great example of the utility of that technology, right? You've given us two examples of lives saved, not to mention the huge number of complications probably avoided as a result of it. So thank you and congratulations. Does anyone
Yeah.
have question or
Can I
comment?
jump in for a second?
Please
I
do.
just want to showcase as well. I think that, thanks, Jerry. This is a great summary. I want to showcase a couple of small bits about how this project kind of fits in with a more longitudinal project that's ongoing in Uganda that some other folks in the emergency medicine department and our global health team have been working on. And so it is one piece of a larger puzzle. And with that, the kind of multifocal approach using distance education with technology and in-person visits creates a longitudinal approach, but also a sustainability aspect, which is super important and fits within that goal of the Health Legacy Fellowship funding, which is kind of amplifying and also and just kind of like bringing some additional investment time and support, but also thinking about sustainability as this fits within kind of a broader context. So the examples of lives saved is meaningful and extraordinarily remarkable. The longitudinal education will sustain beyond that time as well. So thank you, and thanks for sharing all that information, and great project.
Yeah, that's great. Thank you, Dr. Douglas. Well said. I think we'll move on to our next presenter, Dr. Rizul Naithani, who is from the Department of Ophthalmology. Rizul, over to you.
Thank you, Dr. Rousseau and Dr. Douglas. I'm really excited to present. And let me just go ahead and share my screen here.
I'll also say if anybody has specific questions as we're going along, please feel free to pop them in the chat, and we'll try to answer them both in real time and then certainly at the end. So thanks, everybody.
All right, so is everybody able to see my screen with the PowerPoint?
Yes.
Yes.
Okay, perfect. Good evening. My name is Dr. Naithani, and today I'll be presenting comparative evaluation of patient-reported quality of life using the Indian Visual Function Questionnaire and a modified glaucoma symptom scale that will be used for patients comparing minimal invasive glaucoma surgery with phaco, emulsification versus trabeculectomy with phaco in patients with glaucoma in southern India. And some of these wordage will be better explained in the later slides. I'd like to thank the GW Global Health Legacy Fellowship. Without it, this project would not have been completed. And starting out with our background, so glaucoma is the leading cause of irreversible vision loss around the world. It's estimated that 11 million people over the age of 40 are affected in low and middle income countries. The issue with glaucoma and how we describe it is that elevated intraocular pressure is the primary modifiable risk factor that leads to optic nerve death. And the optic nerve is a cable that connects your eyesight to your brain. And so it's a very important component of your eye. Surgical interventions usually are required when anti-glaucoma medications or laser therapy aren't helpful in preventing glaucomatous progression. And usually in patients with glaucoma over the age of 40, they often require cataract surgery as well. And so in low middle income countries, it becomes very convenient to be able to do both glaucoma and cataract surgery at the same time. The purpose of this study is that although trabeculectomy, which is a surgery where we create an alternate passage for fluid within the eye to escape, is the gold standard, it does have its cons with subsequent infection rates and just overall poor management and heavy duty work from the patient's end to maintain it. And so newer technology or surgical methods have included minimally invasive glaucoma surgeries that are not necessarily widely available yet in rural India. And often with MIGS, you have faster recovery, lower complication rates, reduced postoperative medication burdens. And so our study was basically looking at how this compared to trabeculectomy with standard cataract surgery. And we also looked at clinical measures and patient experiences in the study because quality of life is also an added component to patient success rate after surgery. So how we evaluated all of these measures was that we used vision-related quality of life that was specific to the Indian population, and it's a verified measure that has already been created. And we also used a modified glaucoma symptom scale to evaluate the subjective components of our study. This involved daily activities, mobility, social interaction, the mental health component to it. And the objective components, in addition to the subjective, looked at the pressures after the surgery, the number of glaucoma medications the patient after the surgery needed, visual field outcomes. How peripheral is somebody able to see after the surgery? Has that been restored or has that remained about the same? And OCT findings. Now, OCT is a very objective measure where we look at the health of the nerve. How thick is the nerve? And essentially, that is done 6 months after the surgery to be able to see if there is any benefit of the surgery that the patient has exhibited. Usually, patients are unable to evaluate for themselves these later, objective components, which is why subjective components like the quality of life and the glaucoma symptom scale come into use because that's very personal for the patient and they're able to feel it. So our study design was a prospective longitudinal cohort study. It's non-randomized because obviously designing or allowing a patient to choose which surgery wouldn't be very wise. It is based off of the institution's protocol on which surgical method is best and beneficial for the patient. We started recruiting in March 2026 after processing 2 IRBs, one at Arvind and then here at GW. And we are recruiting from 2 sites, one in Pondicherry and the other is Thirunelveli Valley, which is about 2 hours away. The group 1 patient will go through the phacoemulsification and the minimally invasive glaucoma surgery, and group 2 comparing is phacoemulsification with trabeculectomy. And like I said, allocations based on routine clinical care. The inclusion criteria involved patients between the age of 18 and 80, and the open angle glaucoma variants we used are listed here. Usually, because we're doing a combined surgical comparison, every patient must have cataract surgery requirement as well, and the best corrected vision must be better than 20/40. And then written informed consent was also obtained, or that person should be able to give written consent. The exclusion criteria, just to kind of run through it very briefly, is the patient must not have so advanced glaucoma that their mean deviation in the visual field excludes them from getting minimally invasive glaucoma surgery. Because at that point, when severe glaucoma is indicated, we always have to choose trabeculectomy in that case. And then the patient must not have any coexisting ocular conditions that can confound the quality of life or the visual outcomes. And then, of course, the main thing in glaucoma has always been about follow-ups. So if a patient is unable to follow up, that would also exclude them from the study. And then this is kind of how the patient-informed consent or patient information sheet looks like. And of course, we translated this into Tamil, and I'm unable to speak Tamil, so I'm sure all of you guys probably would appreciate the English version of this. And then this is the sample size calculation we did, and we used the 90% statistical power with the p-value of 0.05 to be able to define significance. And then we hope that there's only a 10% anticipated attrition rate. The required sample size for minimum collection is supposed to be 68 patients per group, with a total patient population of 136 combined in both groups. And we've already talked about the outcome measures, but here they are again. And then this is kind of a nice table to outline how the follow-up schedule will look like for each of those objective and subjective measures. Looking at baseline, meaning prior to the surgery, and then post-op day 1, month 1, 3, and then 6. And of course, as you probably see, the visual field can't be done post-op day 1 because vision is often very poor during that period. And so post-op month 1 is usually when we have patients be able to properly do the visual field test. And if anybody has ever done a visual field test in their life, they know how cumbersome that can be. And so here's the statistical analyses that we are hoping to do once our data is finally collected. We hope to do independent t-test and just descriptive statistics for baseline characteristics. And just a note, we're not trying to create a relationship or causal relationship between the quality of life and the different types of surgeries here, because as you know, this is a non-randomized study for ethical reasons, but we hope to possibly incorporate propensity analysis to be able to draw proper conclusions, to be able to go over any biases. And then of course, expected outcomes, in both groups, we do expect that they will lower the pressures and reduce the anti-glaucoma medication burden, and then ultimately improve quality of life scores. But we hope that because the MIGS is a faster recovery, better symptom management based surgery, that will be better appreciated by a lot of patients, at least subjectively. And then this is just a preliminary review of how the tables will look like once our data is completed. As you can see, we've included educational components to this, what the occupation of that person is, what the income range is, and also the baseline characteristics here, not just of the patient themselves, but, looking at the characteristic of their eye, and how it looks before and after. One of the things I wanted to say about Arvind is, when I went and rotated there, they have a separate hospital building for those who are non-paying and those who are paying. And most of the time, one of the reasons why this surgery is so important is that the patients who go through the non-paying or subsidized component of care, they are often relegated to the trabeculectomy site or arm of things. And as you can imagine, those are patients who live in the most underserved portions of our society. And so infection rates and being able to manage their disease outcome is quite different compared to those who are able to afford a much different lifestyle. And so this is the reason why this study was so important, to be able to give universal health care to even the people who can't afford it. And so here's the surgical perioperative and postoperative characteristics we hope to incorporate. And we have a pretty lengthy list of things that we are collecting at the moment. And this is just a small snippet of what we hope to collect during this period. And then here's the clinical outcomes over time. And then, like I said, the clinical significance, this is going to be the first comparative quality of life study of its kind in southern India. And it will be supporting evidence-based surgical decision-making and may even guide glaucoma management in resource-limited settings. And these are my wonderful research coordinators that I met at Pondicherry. At the very back is um, I'm sorry, Jayanthi, and then at the very front is Sai, and both of them have been really, really helpful in trying to coordinate care and telling me how many patients they've recruited. And they were able to also manage the Tirunelveli site. I wasn't able to go to Tirunelveli because during the time I went, the temperatures creeped up so much that it became very unsafe to be able to travel by train there. But I want to also introduce Dr. Upadhyay, who's in the middle. She's the attending who I'm working with, and she's also working here at Michigan in person after this project, which is great. And then this is how Pondicherry looked like. I know one of the things that one of the alumni parted to me was to be able to explore the surrounding area, to be able to see the patients and how they live in general. Um, and I will say that it has been about 30 years since I last went to India, and I've never been to the southern part of India. And I fell in love with how simple individuals are, and how respectful the patients were in the site. It is perhaps one of the biggest joys of being a physician to see the world in a way that many people aren't able to. You see the pains of people through private conversations, and you get to maybe help in the journey of healing in a small component, in a small way that you can do so as a physician. Um, and last thing I wanted to kind of go over is, globally, at least 2.2 billion people have near or distance vision impairment, and at least 1 billion people could live without having to go blind unnecessarily. 1 in 2 people who need cataract surgery do not have access to surgery. And so my hope with this project is that not only do patients have a solution to cataract surgery, but also have a solution to glaucoma surgery, which often gets pushed to the side because, like I mentioned, follow-up care is really important. And unfortunately, with a lot of mission trips, it's a one and done type of thing, and we're unable to sustain that component of care. But I don't want to take away from too much of everybody's time, but I wanted to conclude from this PowerPoint and see if anybody else had any questions.
Well, thank you very much, Dr. Naithani. That was beautifully presented. It's a well-designed study, and you've articulated the scientific and very humanistic reasons why it's important. So thank you.
Thank you.
Are there any other
Yeah,
questions? Go
I'll
ahead.
just chime in for a second. Dr. Nathani, thank you. I think you have a very kind of well-designed research project, but also really at the end kind of brought that the kind of global perspective to light. Very well said from the mouth of an ophthalmologist about how you have the opportunity to really see things in a different way. So I appreciate that very much, and look forward to hearing more about the results and seeing how this project grows. And lastly, that notion of sustainability, again, I think that's a really important common theme that you brought through at the end as well. So thank you for that.
Thank you.
I was trying to find a way to react on Zoom and, heart something, but I couldn't find it. But that's how I felt. So I really appreciate it. I don't see any questions, but again, anyone who has a question, pop it in the chat.
I will say
And
this PowerPoint is like 50 PowerPoint slides of all the things I saw in Arvind. I'm happy to send it to any of the alumni members who helped pave the way for this legacy fellowship.
Yeah. Please do send your slides to us. We'll be very eager to follow along as the results come in. Thank you again. And now we'll go to our next presenter, Dr. Timothy Singer from the Department of Neurosurgery. Dr. Singer, you also have a very interesting and well thought out project, and we're eager to hear about it from you. Please proceed.
Okay. So firstly, good afternoon, everyone. I am very grateful to be included as part of this initial cohort of GW Global Health Legacy fellows, and as my co-fellows have said, we are all so grateful to the Davis family, as well as to Dr. Douglas and Dr. Rousseau for guiding this opportunity. I have been working for the past year on a project focused on identifying how neural tube defects, which are the most common pediatric congenital neurological disorder, are influenced by exposure to heat during early gestation, and the links between actual neurosurgical disease and climate change. And so I'm looking forward to sharing a little bit of an update on how things are going. And so I am just briefly, bit of background. I'm in my 5th of 7 years of training at GW. I initially was a pediatrician, which is partly how I got interested in this disease process and also in these patients. And I studied the influences between climate change and health while I was in medical school. I'll be pursuing a career in what's called functional neurosurgery, which is the subfield of neurosurgery that's all about quality of life, everything from movement disorders such as Parkinsonian tremors to patients with seizures and epilepsy who need resective surgery or focal surgery. And so this work is in line with that because it really is about how patients, all neurosurgery is about how patients experience every day. Obviously, all medicine is about how patients experience every day, but it's really meant to be targeted on symptom management and quality of life control, which spina bifida patients certainly endure. And so in conjunction with the Global Health Legacy Fellowship, I've also been working with some folks over at Children's National, including my good collaborator and friend, William Randall, who's one of our great medical students here at GW, who's on the call today. And so these two projects have been concurrent and developing together. I'll mention a little more about that as we go. So Tanzania is among the highest countries, has among the highest prevalence of spina bifida in all of Africa. And one of the major preventive efforts that can help reduce the burden of spina bifida is the fortification of grains with folic acid. And excitingly, there are several countries who've been working very hard, and much thanks to the advocacy of folks like Dr. Rousseau and the GABSIF initiative, which is a true multidisciplinary international collaborative that is focused on driving global health policy to increase folic acid fortification of staple grains and other foods in order to reduce the burden of spina bifida. And so Tanzania is one of the countries who has adopted a folic acid fortification policy, as this is from just last year, but there's still some significant work to go in terms of reducing this very preventable congenital malformation. Most spina bifida and neural tube defects, which are not one and the same, they're terms that are used synonymously, but there's a slight difference, are indeed preventable through this measure. Briefly, there is a fair bit of data that's been out there for several years now that shows that the early neural tube formation, which is the closure of the neural tube, and ultimately, the part of the spinal cord that contributes to the distal nerves that control everything from lower extremity function to bowel and bladder function, as well as some gut motility, can be adversely affected by elevated ambient heat exposures, usually above 30 degrees Celsius. previous for a not very prolonged amount of time, as few as just a few days during early gestation, when the neural tube actually goes through the process of forming and doing its folding process in the first weeks of gestation, really the fourth week of gestation specifically. And so to begin, what we wanted to understand was, because of the relatively high burden of spina bifida and other neural tube defects in Tanzania and also throughout East Africa, we wanted to look at national data within the country to compare that with ambient heat exposure during gestation and see if retrospectively those data align. And so what we've been doing has been, first and foremost, to go through and look at what is the established research on this subject, so that we know fundamentally what we should kind of expect to find, and then we're going to go through and build our data out from there. So I've been very, very fortunate to have an outstanding team of highly motivated and smart students and other researchers assisting with this project. And I want to highlight especially the extremely competent and impressive work of Daniela Perez-Jadid, who has led a lot of the initial literature work on this. Daniela is an MD who has been serving as a postdoctoral fellow at Rutgers, and she helped basically steer an extensive literature review to make sure that we now have a comprehensive snapshot of exactly how ambient heat exposure is thought to influence the incidence of spina bifida. And what we're seeing are odds ratios on the scale of 1.5 to 2. And so here's just a quick snapshot of her work, showing that there are several studies which show both nationally here within the United States, particularly in the South, in places like Georgia, as well as internationally, that the exposure to ambient heat, particularly during early gestation, even for just a few days, has this significant risk factor effect on spina bifida incidence. So we have a well-organized scientific basis to look into this question, and we're submitting our first manuscript here that Daniela will be the lead author on, and on which I am the senior author in just the next few days. It's just going through last revisions now. We did share this work, of course, part of the directive of the GW Global Health Legacy Award is to make sure that we are indeed presenting our work at forums widely. And so Danielle and I were pleased to share this with recently at the GW Climate and Health Research Day in April. And then also this, of course, has been submitted for review to the National Neurosurgical Conferences upcoming this fall. Moving on from our sort of scientific backing, we now need to go through the process, and we are actively working on this, of building our meta model. And this idea behind our model is to take the sort of existing known climate projections and to get a sense of what is the actual epidemiology of the burden here. And so we've begun to work this out. Here's just some snapshots of data from the World Bank, which show under different climate change scenarios how ambient heat temperature is changing over time. So we can get some sense, not just of the immediate epidemiologic burden that the country faces, but also how that might project out over time. The whole purpose here being to take a multi-pronged approach to having a more robust and honest estimation of how populations will be affected, so that interventions can be targeted accordingly. And so what we've begun to do is building out this model using the expected parameters that you would think of, everything from temperature deviation, humid cover, gestational age, birth registry, is to look then back at what do we know at baseline here about spina bifida within Tanzania. And so these are some initial chloroplasts that our team has put together, which basically show that among the poorest areas of Tanzania in the north central part of the country, those are also those with the highest burdens of spina bifida, at least that we have existing data about from our literature reviews. And so What we'll be doing from here is, now that we have the sort of idea of moving from our initial, research review to building out the model, is we're actually now in the process of working with our Tanzanian collaborators at the Muhimbili Orthopedic Institute, where we've been working now for almost 2 years on a couple of projects to both gather all the national spina bifida data into a single registry. And that's going to be the goal sort of final phase outcome of this work, is to establish a spina bifida registry in country where the different regional sites that are treating spina bifida are able to, which means surgically treating it and also caring for those patients and their families, are able to funnel their data into a single repository, and to cross that with climate data. And this project has certainly not been done on this scale in an East African country to date that I'm aware of. And so we are going through the ethics approval process in Tanzania. It is a time-intensive and, as you can see, not a cheap process, but one that is enabled fully by this grant, and we wrote into our budget accordingly. And thanks to the work of Dr. Shabani, who is the chief of pediatric neurosurgery at Muhimbili Orthopedic Institute and one of the leaders of the Tanzanian Neurosurgical Society, which Dr. Rizul, amongst others, has been very involved in the leadership and organization of. We've had strong support from some of the most established neurosurgeons in the country to help us get this project off the ground. So work is indeed ongoing. I wanted to highlight briefly the work of my good friend and collaborator, William Randall, who has recently been in Tanzania presenting some of the work that we've been doing on operative video to analyze pediatric neurosurgical cases in order to help improve neurosurgical training work. William recently was in Tanzania, in part funded through this grant, to help get some of the legwork going for our project. And then from there, he is helping establish some of the next steps here, and has also been working with some of our collaborators at Children's. So finally, there is precedent in Tanzania for this sort of work. We'll be building out a database that I mentioned, which is currently been done for stroke within the country. So we have also been reaching out to folks who've done this on a national scale to get a little bit of guidance. And so our immediate next steps will be traveling back in the fall and in the spring. Again, I'll be going. Hopefully, William will be going again. We've got our manuscripts in process. We're building out our model, and our team is moving along. So we obviously have a lot of work to go. There are certain limitations that we have to be cognizant of. Obviously, there'll be gaps in our data set that we're trying to address. But all told, none of this would be happening or possible without the support of this grant. So we're looking forward to hopefully informing some of the ongoing policy on folic acid care, folic acid distribution, spina bifida care, and ultimately epidemiologic projections here. And we've had a wonderful team. Here are some of the members of it, including our good friend Romani Savas, who's a neurosurgical resident in Dar es Salaam at Muhimbili Orthopedic Institute, who's been instrumental in also guiding this. And of course, I want to acknowledge the neurosurgery department here at GW for supporting this. It is a tricky thing to do global health work during neurosurgical training, during any residency training, frankly, and it would not be possible without this support. So thank you to the Davis family, as well as to the leaders of the GCCA for helping support this. I'm quite grateful, and I'm happy to take any questions.
Well, thank you very much, Tim. That is a ambitious and multi-focused or at least polyvalent project that you have that deals with attacking all the preventable causes of the most serious congenital neural defect that there is. So that's exciting news for the world, as well as for Tanzania. And also the things that we like so much about this project is that it's sustainable. It's leading to the creation of a spina bifida registry. And as you briefly mentioned, a surgical video database that will be very helpful for the surgical care of these patients. So thank you. Dr. Douglas, any comments from anyone in the audience?
I echo all of that in terms of partnership, sustainability, obviously scientific rigor, and impact and outcomes. So thank you for the work.
And with that, Dr. Douglas, I think we can call it a day for this webinar. And thank you all so very, very much.
100%. Thank you. We look forward to seeing more results and sharing more stories of impact and staying in touch. Thanks, everybody.